Okay, let's get started. So hi there. My name's Chris Paton. I'm going to be talking about evaluating digital health systems and interventions. So for people who don't know me, I work part-time for the University of Otago in New Zealand, where I live at the moment, and part-time for Oxford University. So I moved to New Zealand just over a year ago. And I've been setting up a new digital health program, postgraduate program, digital health here in New Zealand. And I work across the Department of Information Science, half in the Department of Information Science, half in the medical school at the University of Otago. And I'm also a clinical researcher at Oxford. So I was in Oxford for quite a long time, about 8 years, and working for Professor Mike English's group and doing research in Kenya and Vietnam. And I'm on Twitter and LinkedIn if you want to connect with me. So just to give you a bit of background about me and what I'm kind of interested in. So these are a few of my projects. So these are the ones that are kind of currently going on. So the first one is called Life-Saving Instruction for Emergencies. This is a smartphone app that uses a game engine, a computer game engine, called Unreal Engine, which is the same game engine used for the Fortnite game, to allow you to go into a 3D hospital and learn the steps that you need to do to manage an emergency. So this one being shown here is the steps you need to take to manage a newborn baby who's born not breathing. And so this is now available on app stores and is used in Kenya. We've had about 6,000 downloads of the app. We also did a VR version, so you can see Professor Mike English sporting a VR headset, and this enables you to go into a virtual reality environment and do the same kind of thing. So we use the same models and things, but it's much more kind of immersive and interactive. And this is a project we did a few years ago using the Engage VR system. And again, it takes you through the steps you need to take in order to resuscitate a newborn baby. You can practice
resuscitation and must click.
Okay. We're also currently working on a project in Kenya that uses a smartphone to help differentiate between severe and non-severe pneumonia in children. And this uses technology developed by the Department of Engineering Science that uses a smartphone camera to capture vital signs. And this little video shows the smartphone camera capturing quite similar vital signs to what you would get on a pulse oximeter in terms of heart rate and respiratory rate. And then those can be combined with a decision support tool to help people in rural areas, whether they're clinical or community healthcare workers, for example, diagnose children with pneumonia, differentiate between non-severe and severe pneumonia, which means either they get admitted to hospital and have antibiotics, or they can be managed at home. Also working in Vietnam on the Vital project. So this is a big project that's looking at improving intensive care unit monitoring, decision support using artificial intelligence tools. So this is working with a number of universities in Europe, including Oxford, and trying to see whether we can use AI systems to reduce the cost and increase the availability of digital tools like monitoring systems, and also trying to create decision support type tools for supporting lower cadres of healthcare workers to make decisions, which is quite tricky when you're building ICUs in lower middle income countries. So those are all my kind of interests. So the agenda today, what I'm going to talk about is what is digital health? Why do we need to evaluate digital health? What's required for digital health evaluations? And then hopefully have some discussion about some of the big challenges that we've got thinking about how we evaluate digital health systems and interventions, and why we might want to. So first of all, what is digital health? So digital health is a kind of relatively new term. We used to talk about things like health informatics, which is kind of like the science of computers in healthcare. But quite commonly, so a few kind of government agencies around the world started to call themselves like the Digital Health Agency and NHS Digital and things like that. So the term digital health now kind of refers to the use of digital technologies in healthcare quite broadly. But really, we're talking about moving from paper-based and kind of face-to-face systems to digital systems. So these are kind of some medical records, which you might have seen a few years ago in your GP surgery. And how can we shift those onto being available on computers and online, on the web, on iPads, things like that. And if you go into a hospital nowadays, you'll see lots of different types of information systems used. And when we talk about digital health, we quite often talk about these types of systems. So they might be the electronic health record system, there might be the picture archive and communication system, there might be a patient administration system, a pharmacy informatics system, a laboratory information system, clinical decision support systems, which is some of the things we're looking at in Vietnam, and lots of other systems. And there might be hundreds of different systems in a big hospital, all doing lots of different things. And then also we've got this kind of new kind of wave of kind of mobile apps and smartwatches and sensors and things like this. And quite often these are called digital health interventions, where they're like a new thing that you're a bit like a new drug or a new medical device, but really it's software and new types of sensors that are doing things. So things like the Apple Watch detecting your heart rate, or in Australia, there's a thing called My Health Record, which is enables you to access your national health record on your iPhone. So why do we need digital health? So I thought I'd throw this one back out to you guys and think about why. why do you think we need digital health? What's going to be the advantage? So if you can post, try and keep it a bit interactive. If you can just post some ideas in the chat about why you think we need digital health systems. Anyone got any thoughts on why we want to digitize systems? What's the kind of benefits of doing that? Have a go at posting in the chat if you've got any thoughts on that. Here we go. Improved access for some, that's a good idea, yeah. Efficiency, yeah, very interesting. Speed, Mike English saying, yeah. More efficiency, yeah. So efficiency, speed, potentially improves accessibility of medical records for clinical management, audit and research, yeah. Ease the flow of information, cost savings, batch processing, big data opportunities, yeah, very good. Okay, so all great ideas. So this is about kind of the idea that digital can speed things up a lot. It's a lot quicker to get access to something digitally than it is to try and find the notes. I remember when I was a junior doctor, way back in early 2000s, my job was mostly to go down to the X-ray department to dig out a film or to try and find someone's records that were on another ward and bring them around for the ward round, that kind of thing. So digital technology is supposed to help with that kind of thing. Okay, reduce medical error. I like that one. That's good. Okay, so Muir Gray's got quite a nice kind of quote that I use often. So Muir Gray's a public health professor and quite a famous person around in the field of digital health. And he says knowledge is like water. So clean, clear water transformed health in the 19th century, and clean, clear knowledge will transform health in the 21st century. So that's really what we're trying to do. We're trying to improve the knowledge that we can get about healthcare to make better decisions and to improve care. And one idea that I quite like for thinking about digital health is this idea of learning health systems. So how can we turn hospitals and larger health systems and even smaller clinics into learning health systems, so learning systems. So this idea that we've got all these digital tools that we're using for booking in our patients or recording what transplant was done, or all these little things that we're recording in all of these digital systems. How can we use that data to improve the care that we provide? So this might be immediately just looking back over the care of your patients recently and finding ways that you can improve your own practice, or it might be up to conducting huge research projects across lots of different healthcare institutions And this idea that by using the data, we can learn from what we're doing and make improvements. And some of those improvements might be non-digital. They might be we should change the types of drugs we're prescribing, might need better staffing, but also it might be that there's an information system that we can put in that's going to help us improve care. And then we can monitor whether or not that information system is improving care through the same kind of cycle. So I quite like this idea of learning health systems. So what's happened with digital health? So digital health is quite a trendy topic at the moment. And over the last kind of 20 years, we've gone from a position of not very much digitization at all in healthcare to enormous digitization in healthcare. And a large driver of this was government programs. So those old enough might remember the National Project for IT in the NHS. That spent 10 billion on trying to put in national electronic health record systems and various other things. And the US government also, when the global financial crisis happened, they put in this huge investment to try and get hospitals to adopt electronic health record systems and clinics as well. So governments have been driven a lot of the adoption, and this is the adoption of using electronic records for what they call meaningful use. And meaningful use was the term that they wanted to move in this global financial crisis stimulus that they did in the US. They wanted to move from a situation where they were just using digital for record keeping and billing and that kind of thing to using it for improving clinical care. And this is before and after the stimulus, how many hospitals were claiming funds from the government for delivering what they said was now meaningful use of clinical information in just a kind of 2-year period. And in the private sector as well, there's just been huge investment recently in digital health. So this is a graph of venture capital that's getting put into digital health. And so it's kind of been gradually increasing, and then 2021, it's really exploded. There was a kind of $30 billion venture capital investment in 2021. And there was a lot of interest in digital health systems due to the shift to kind of virtual care and that kind of thing with coronavirus. So one of the big challenges and one of the kind of limits on all this investment was how do you actually pay for digital health if the government isn't investing these billions and billions, which they started off doing and kind of started to not do anymore. How do you get paid? How does a company get started? That kind of thing. And recently, particularly in the US, they've started to say that things like AI algorithms can be paid for and charged in the same way that you might have a procedure or an operation or a visit to the doctor and that kind of thing. So this is, for example, the use of an algorithm to identify signs of a stroke on a brain CT. Whenever that's used, they can charge $1,000 for the person who developed the algorithm. Obviously with the COVID pandemic, people will have probably used a smartphone or used their computer to have a teleconsultation if they've needed to talk to a specialist. And there was a big shift particularly in GP appointments, shifting from face-to-face consultation, which was the norm, to this not in-person consultation after lockdowns. And McKinsey, the management consulting firm, did this kind of projection of the effect of this on the kind of market for digital health in the US, and they said that 20% of all of the government spending on healthcare could switch into virtualized healthcare. So that means that a lot of what was traditionally done in the face-to-face non-virtual healthcare could shift into digital. Okay, so why do we need to evaluate digital health? So why don't you have a think about this and think about what is it that we want to evaluate about digital health? Why do we need to evaluate digital health? Why can't we just buy these systems, download the apps, just start using them? Why should we be interested in evaluation? What's the reasons for that? So post that in your chat if you've got any ideas about why we might want to evaluate digital health systems. So Jake Knight says, because almost all mHealth has been abandoned eventually. Okay, yeah. So if we did evaluations, perhaps we wouldn't get so much projects starting and then failing. We need to be sure that they're inclusive, compare different systems. Does it really meet the potential? What's the opportunity cost? That's a good one from Sassy. And to assess their value for money, cost effectiveness, usability, otherwise not much information, safety, to set standards, need to know that they're safe, not harmful, quality of assurance, compare benefits to comparators, acceptability, ensure the staff can use them effectively and efficiently. Yeah, this is great. And scaling up, that's a very important thing, isn't it? Okay, so we're going to talk about all of these things. So let's get started. So the kind of requirements for evaluating digital health systems are different in different countries and different regions. But the UK has done quite a lot of work over the last 10 years or so, and is probably the kind of closest example that most people will be familiar with in this kind of forum. So we're going to talk about the UK requirements for evaluating digital health, and then we'll touch a bit on some of the things that the WHO have been saying, but we'll focus mostly on the UK. Okay, so I don't know if people are familiar with the NHS service standard. So the NHS has got a group called NHS Digital, and they've developed a digital service manual. And part of this digital service manual is the NHS service standard. So the service standard is a set of guidelines that anyone providing digital services within the NHS should be following. And quite often that's projects that are run by NHS Digital, but also increasingly it's projects that are being purchased to be used in the NHS. And the service standard builds on the UK government standards. So the government design service, which is responsible for kind of digital across the whole of government, so how you pay your taxes and parking fines, all sorts of things, ordering new passports, all of these digital services the government provide, they have a service standard, and the NHS service standard is basically that standard plus 3 additional things. So I'll just talk about that because some of the things that people have said here about why we need to evaluate come up in that standard. And first of all, it's understand users and their needs in the context of health and care, work towards solving a whole problem for users. So that's saying that don't just solve a little bit and then they're stuck after that. Provide a joined up service across all channels, make the service simple to use, make sure everyone can use the service, create a team that includes multidisciplinary skills and perspectives, use agile ways of working, iterate and improve frequently, respect and protect users' confidentiality and privacy, define what success looks like by being open about how your service is performing, choose the right tools and technology, make new source code open, so have open source code for new services you're providing, use and contribute to open standards, common components and patterns, and operate a reliable service. So all of those are basically, if you're doing any IT project for the UK government or funded by the UK government, you should be doing all of these things. I'm not sure you could say that that is 100% true, that people are doing all those things, but that's what the NHS service standard is about. And then there's 3 additional things that the NHS service standard says on top of the kind of normal government standards. That's one is to support a culture of care. The next one is make your service clinically safe, and the last one is to make your service interoperable. So the culture of care is about making sure that you're not just being kind of hard-nosed. It's not about the finances. It's not about the hierarchy of the NHS. It's about caring for patients, looking after patients, making sure that you are acting in a caring way when you're thinking about developing digital services, because the NHS is a caring organisation. And then number 17 is making your service interoperable, and that's about how we connect all these different systems together, which is a big topic that I'm not going to go into. But what we'll focus on is really what we think about generally in evaluation in healthcare, which is about making sure things are safe and making sure things are effective. So how do we make sure things are clinically safe? So this is what the NHS service standard says. So digital information tools and services have potential to cause patient harm. So you have to make sure that you actively manage safety risks associated with your content, service and processes. So this means having a clinical safety officer. So this is a clinician with professional registration who has been trained in clinical risk management and accountable for clinical safety. And if you're delivering healthcare information, it has to be checked by qualified clinicians to make sure it's accurate and evidence-based and clinically safe. And you need to meet the needs of your most vulnerable users, for example, making sure patients can request a translator or by flagging safeguarding needs. So there's two tools that have been developed for helping people with this process. They're called the DCB 0129 and the DCB 0160. So the 129 is the standard for people who develop digital health systems and software, and 160 is for the organisations when you're going to purchase a system or when you're going to implement a system. And they're kind of a set of checkboxes to make sure that you've got your clinical safety officer and it's been checked by clinical things, and you've got your all of your risk management, clinical risk management things all sorted out. And that you've got processes for developing things like live safety instance. So you've got operating, when things start to go wrong, you've got a standard operating procedure for how you're going to manage that. Other big area is making sure that the data you collect is up to date and error free. And there's also a whole load of other issues around data that I'll talk a bit about in a minute. So apart from those kind of two DCB standards documents, the other big thing is the NICE's evidence standards framework for digital health technologies. So this is what the NHS says you should be using to show that your systems are going to work for your service that you want to have. If you're using a digital tool for providing services directly, then you are essentially the same as something like a GP practice or something like that, and you need to be registered with the Care Quality Commission, who will inspect you and make sure that you're running a safe service. If your app is a medical device, which we'll go into in a bit more detail, you need to follow the guidance from the MHRA on medical devices. And there's been some changes to that recently with leaving the EU. So I'll mention those a bit in a second as well. If anyone's got any questions on this as we go through, just feel free to type them in or put your hand up and ask any questions or chip in. That's completely fine. Okay, so the NICE Evidence Standards Framework. So I presume most people know what NICE is. It's the National Institute for Health and Care Excellence. So they help with appraising evidence and developing kind of standards and guidelines for how we use various things in healthcare, like drugs, medical devices, and now digital health. And so the NICE Evidence Standards Framework helps technology developers inform their plans of how they're going to be evaluated and what kind of evaluation they need. And they help decision makers who are considering commissioning a digital health technology think about what kind of evidence standard is needed before they purchase it or put it into place. So this was published in 2018, updated in 2021. And we've just got a message there saying a new update of the NICE Evidence Standards Framework is being launched imminently. Oh, that's very exciting. To update and include appraisal of AI tools, which were previously not included. Okay, very good. Okay, and so just a bit more of the history of it is commissioned by the NHS England and partners with Public Health England and MedCity. And I think MedCity is a kind of group of hospitals and innovation things, which is run by the government in London, I think is what MedCity is. Okay, so the plan behind this was really people didn't really know how to evaluate digital health technologies and interventions. And when they were purchasing them, they didn't really know what kind of evidence was needed before they could kind of say, okay, that's going to be a nice digital health technology, we should use that. But also there's lots of innovation going on, lots of small developers, lots of new companies, lots of companies from overseas and things. And so they had to kind of have this balance of being realistic and achievable for developers, but also giving confidence to the health and social care system. With something that's new and evolving, this is kind of really difficult and challenging. So this is just the kind of handy guideline for how to apply the evidence standards framework. And so we'll go through this in just a second. But first of all, you select your functional classification, and there's 3 tiers that show you the different types of kind of hierarchy of different types of technologies. Find the highest evidence tier for those functions, and then so you identify. So you basically you have to describe what your digital health technology is doing. That puts you within one of the tiers. And then with the tiers, then you look up what evidence is required for your tier. And there's 3 tiers. One is system impact, one is understanding and communicating, and one is interventions. And then in addition to that, there's this thing of identifying specific risks. So specific risks are these things that mean that you'll need a higher standard of evidence because there's particular kind of challenges. For example, have you got users in vulnerable groups? What's the consequences if this doesn't work? Is it going to, cause a big problem and affect people's healthcare? Is there professional oversight? Is artificial intelligence used? And is there a very high cost expected? So just keep those things in mind when we go through, and that's what shifts you from being a kind of minimal evidence required to best practice standards. So if there's no specific risks, use minimum evidence, and if there are specific risks, then you use best practice standards. Okay, so let's start at the bottom. So this is kind of a funny triangle because it's a bit like a pyramid, and you can imagine when you're thinking of it, you would imagine a pyramid with a wide base going up to a kind of narrow top. And that is true in terms of the number of different types of digital health systems there are. So down at the bottom in tier A, this is probably the majority of digital health systems out there. So this is called system services. So this is digital health technologies with no measurable patient outcomes, which provide services to health and social care. So these are things like electronic health record systems, or the NHS spine, or these kind of big services that are used for kind of supporting the kind of infrastructure. And then as you go up, which we'll talk about, there's kind of less and less systems like this, but you require more and more evidence. But just because of the way that they ask you to identify the type of system, it looks like it's the other way up. But that's just to help you kind of understand which tier you're going into. Okay, so tier A, system impact, so no measurable patient outcomes. So there obviously would be patient outcomes if these systems went down, but not really, apart from that, not really kind of measurable in terms of kind of, blood pressure measurements and things like that. And so for these types of systems, there's a number of criteria, and then these criteria will also apply to the other tiers, but I'll just talk about the extra things that apply as you kind of go up from tier A to tier C. So for tier A, the main thing is that it should have credibility with healthcare providers. So this is showing that a digital health technology has a plausible mode of action, which is viewed as useful and relevant by professional experts and expert groups in the relevant field, and show that the relevant clinical social care professionals have been involved in designing and testing the digital health technology, or given their informed approval. So that's the kind of minimum standard. So if you are not vulnerable users, it's not going to cost a huge amount of money, it's not using AI, those are the standards, having a plausible mode of action. But if it has got those things, then you need to have best practice, which is publicly available evidence, documenting that it has a plausible mode of action by experts or expert groups, and show that relevant healthcare professionals have been involved in designing and developing. Okay, so I don't know if people are familiar with the term mode of action. So if you've got a kind of clinical background, you might come across the term mechanism of action quite a lot. So, and I think the difference really is mechanism of action is generally talked about kind of molecules, and mode of action is can be other things as well, like people doing things and machinery working, that kind of thing. But I'll just show you, I think this is something just to keep in mind thinking about digital health. So I'm just going to show you, like, this is the mechanism of action of a drug, and I'll just play it, and I won't play it all probably, but just play a bit of it. So this is kind of how
calcitonin gene-related peptide, or CGRP, is a neuropeptide.
So this is the idea that you've got a kind of molecule that goes into our cells, binds with a receptor that will then block another molecule, binding with the receptor. Then that causes a biological reaction, and then that biological reaction is the reason why the drug works. So I think this is for like migraine medication, and saying if you block a certain kind of receptor using the drug, then it means that some kind of reaction which is associated with having a migraine doesn't happen, and that's the reason why the drug works. And so what they're saying really is that, thinking about that from a digital health, so that kind of adds to your kind of, so that's mode of action. And the kind of question is, what do you think is the mode of action of an app? How do we think about that? So maybe a couple of people might want to type in what you think the mode of action might be for an app, or maybe just actually, we're just in the interest of time, just keep it in the back of your mind. Try and think about how do we think, if mode of action of drug is these kind of biological reactions, what is the mode of action of an app? Anyway, so moving on. So for TRA, there's other things as well. So one is that it should be showing that it's been successfully piloted, that it's relevant, and it can perform to scale. And the best practice for that is there's evidence to show that there's been a successful implementation previously. And obviously that's a bit of a challenge if it's a new innovation, isn't it? So how can we show evidence of a previous successful implementation if it's a new innovation? Also, acceptability to users. So this is something people came up with quite a lot when we're talking about evaluation. So for all digital health from Tier A upwards, you should be able to show that user groups are involved in the design, development, or testing, and provide data to show user satisfaction. And this should be published or publicly available for best practice. It should be contributes to evidence. Should be that it contributes to challenging health inequalities, eliminating unlawful discrimination, and fostering good relations between people with protected characteristics, and show evidence that it's being used in hard to reach populations if it's best practice. One thing there just to say is it's evidence if relevant. So if it's not relevant, it's not necessary. And then accurate and reliable measurements. So data analysis to show that data recorded is accurate, reproducible, has the range of values expected in the target population, and can detect clinically relevant changes or responses. And best practice is to show that, but with quantitative data. So, and then also transmission of data. So when you transmit data, it shouldn't change. And it shouldn't be biased by the value expected. And also best practice is the same, only but shown that with quantitative data. So these things that we've just been through, mode of action, relevance to care factors, acceptability to users, equalities considerations, accurate and reliable measurements and transmission, they are there for all of the tiers. So that's all you need for these system services, but then you go up a tier, you need all of those, and you need a couple of extra things. So the next one is tier B, is understanding and communicating. So this is digital technologies that inform, so provide information, resources, activities to the public, patient, clinicians. So it might be information about a condition. So this might be something like the NHS website when you look up about a condition. Health diaries, so if you're putting in information about your health into a health diary, including fitness wearables, and communication tools that allow communication between citizens, patients, healthcare professionals. So things like what we're doing now, if it was used in a consultation, that would be a tier B. So the extra things for this are reliable information content. So it should be valid, accurate, up-to-date, reviewed and updated by experts in a kind of regularly defined intervals, and comprehensive. And if you're working with vulnerable groups or AI or those other kind of issues, it should be endorsed or accredited by people like NICE or NHS England, or independent accreditation. So, for example, if you're providing kind of health advice on a website, you could use the NICE guidelines. They show that that's the best quality evidence for a particular guideline. You need to collect data on the usage of these types of things. So for the other ones, you don't need to keep showing how well they're being used, but for this, you do need to show how well they're being used. And also, you have to keep showing the value of these. So that kind of comes to this kind of cost effectiveness point that somebody raised earlier. So looking at user outcomes, user satisfaction, ongoing value, and if it's best practice, that needs to be made available to the relevant decision makers. They also need to be safeguarding measures in place. So these are these things like these DCB forms and things. So who has access to the platform? Why are these groups suitable and qualified to have access, and measures in place to ensure peer-to-peer communication has got moderation or user agreements. Okay, so you can kind of imagine what those kind of type B things are, and the type A ones are these kind of big systems, and then the kind of interesting ones are these type C, tier C things, which are interventions. So these are things that could be preventative behavior change, they could be self-managing, they could be treating people or guiding treatment, they could be actively monitoring people, so monitoring your heart rate or something like your heart condition or something like that, calculating something that impacts on a treatment, disease or care, so like a drug dose calculator. So I remember in my career, there's quite a lot of kind of free drug calculators you could download onto your phone. So these would be in the top tier interventions now, because obviously you can imagine if there's a bug in it and it makes a mistake, it could be quite a serious issue. Or things that diagnose a specified condition or guides diagnosis. So these are those. So at the top tier, we've got everything that we had in tier B and everything that we had in tier A. So I won't go through those again. I'll just mention the extra things that we need in tier C. So this is the demonstrating of effectiveness. So these are for treat, active monitoring, calculate or diagnose functions. So if your app or your system is treating, actively monitoring, calculating or diagnosing, at a minimum, if you're haven't got vulnerable users, not using AI, it's not going to cost a lot of money, not going to have a big impact, that kind of thing, you need a minimum of a high quality intervention study, either experimental or quasi-experimental, showing improvements in the relevant outcomes, such as diagnostic accuracy, patient-reported outcomes, clinical measures of disease, healthy behaviours, physiological measurements, so you use satisfaction and engagement, and you can also use other general outcome measures, and it should be compared against the current care pathway, such as a commonly used intervention. And if it's best practice, so if you are using those vulnerable groups, it should be a high-quality randomised controlled trial with a relevant comparator demonstrating consistent benefit in clinical outcomes in the target population. So you can't just say user satisfaction and engagement. You've got to have, an RCT showing benefit of clinical outcomes. Alternatively, if there's been these systems around for a while, you can say there's evidence from previous well-conducted meta-analysis of these types of things that show that they work. So there's a few examples of that. So you might think with digital health there couldn't really be examples of that, but there are examples. So, for example, randomized control trials. There's been lots of randomized control trials of digital health technology. So, an example is computerized decision support systems. This is just a randomized control trial that was published reasonably recently, showing kind of minimal or no effect. There was a meta-analysis of clinical decision support systems that showed that they were effective in certain conditions and systems. So if you could potentially use these kind of studies to back up your Tier C kind of evaluations. And then people like Cochrane have also got these kind of Cochrane reviews of various digital health technologies. There's not very many really, but some that have been shown to be effective are things like mobile phone text messaging for smoking cessation. So there's been quite a few large RCTs of mobile phone text messaging for smoking cessation. So if you want to quit, you can sign up to a quit line, and they'll send you kind of motivational text messages, and you can say, I've got a craving, and it will give you some guidance and say, have a glass of water, or get up and go for a walk, and that kind of thing, and give you motivation of how you can quit smoking. And that has been shown with multiple RCTs to be effective. I saw one for this group. I thought it might be interesting. There's a Cochrane review of routine health information systems for health systems strengthening health systems management, and that shows that there's poor quality evidence for that. So if you were proposing that, then you might want to you might have to say you're going to do your own trials. Okay, so the other things you have to do are if you're, one part of it is at this top is for treat, active, monitor and calculate or diagnose, but there's also preventative behavior change. So for preventative behavior change, the guidance is to use recognized behavior change theory and recommended practice, which is aligned to NICE guidance, relevant professional organizations and appropriate for the target population. So you can't just make up your own new behavior change kind of ideas. You have to use the kind of evidence base around behavior change theory and that kind of thing. And it should be published, if it's for best practice, it should be published evidence to show that it's going to work. So this is kind of behavior change theory, this process of understanding the problem, identifying options, and then choosing behavior techniques that work. So this is from Susan Mitchell's work. And this is the behavior change wheel, which people might have seen, and the COMBI framework. So these are the kind of tools that if you were developing a behavior change digital health intervention, or thinking about adopting one, if it followed these kind of evidence base and theories, then that would be aligned with the NICE standards. Okay, so let's just talk briefly before we get into a bit of a discussion about CE marking and medical devices. So there's previously medical devices and digital health were kind of two separate areas, but as most people will probably realize, these kind of two things are merging. So a lot of medical devices have things like data that's collected through them, which is then kind of displayed, or they might have an app that interacts with the medical device. And this is kind of causing quite a few problems in terms of how we can think about how we regulate it. So there's this established way of regulating medical devices, and then this kind of challenge of how we regulate digital health. And then on top of that, the UK has left the EU, which means that it's had to come up with its own regulation around medical devices, and then apply digital health regulation onto that as well. So there's been a lot of discussion, a lot of debate around this, and basically they'll be moving to a UK CA mark as opposed to the CE mark, and but will generally follow the same idea of if certain types of digital health interventions will be classified as medical devices in the similar way and regulated in the similar way as they were under the EU, and require this UK CA mark as they would have required a CE mark under the EU. And so finally, just the other thing that's been brought in fairly recently. So this evidence standards framework's been around for a few years. And then more recently, there's been this thing called the digital technology assessment criteria. And so because I've been talking for quite a while, I'll just play you a short video just to give you a kind of snapshot overview of that. And they too do reference, well, the digital technology assessment criteria references the evidence standards framework. So it's kind of related, but let me show you this.
Is your new digital...
So can you just, someone give me a thumbs up if you can hear that. I've muted that, but I'm not sure if you can hear it. No, okay.
It will give staff technology DTAC ready. Digital Technology Assessment Criteria for Health and Social Care, or the DTAC for short, is a set of criteria for organisations to use when introducing new digital health technology. Using it will give staff, patients and citizens confidence that the digital technology they use meets our national minimum standards on clinical safety, data protection, technical security, interoperability, usability and accessibility. The DTAC brings together legislation and best practice from across the health and social care ecosystem into one place, so assessing products is simple, quick and consistent. So, who does what? NHS and social care organisations should assess any new digital health technology products against the DTAC as part of each new procurement process or contract renewal, including staff or patient-facing apps, systems and web portals. Tech developers can use the DTAC to make sure their products meet our standards and prepare for assessment. These assessments will be carried out by local health and social care organisations. Make sure your digital health technology is DTAC ready. Find out more at www.nhs.
Okay, so sorry that sound was a bit messed up. Hopefully you could hear that. So basically, I won't play that music again. The DTAC helps. So if you've got a system that's going to go into the NHS, you have to fill out this DTAC form, which is essentially quite a long Word document with these different sections that I've got listed here. And then for each one, it will reference various forms and things that you need to fill in, like those DCB forms, and also reference the evidence standards as well. To say that you have to show the publications and things like that you've seen, and then you've got this kind of package of information that you can then use to say we've fulfilled all these criteria. So you've got these company information, the value proposition, technical questions. So these are clinical safety, data protection, technical security, interoperability criteria. So clinical safety, that's DCB 129 and 160. Data protection, this is all the rules around GDPR and data protection rules. Technical security is going through cybersecurity assessments, making sure that you've thought about all of the different ways that the system might have security issues. And then interoperability, and that's this kind of big area that I'm not going to talk about too much, but how the systems kind of connect to each other. And then also thinking about these usability and accessibility. And these criteria all hark back to that thing that I said at the very beginning around the NHS service standard. So those 17 points all get kind of represented in here in some way, saying that, have you designed this in an agile way? Have you co-designed it with end users? Have you checked that it's safe? Have you checked that it's secure? You're looking after people's data, all those kind of things. And essentially you have a Word form and then a kind of package of documents, including things like clinical risk registers and things like that. Okay, so that's the NHS and how they kind of say you should evaluate digital systems. There's also different approaches in different parts of the world. So just one big thing that probably you should be aware of is in the US, they've got this thing called safety enhanced design. And this was all tied up with the stimulus they did, that $25 billion stimulus that they put in, and said that the systems that they're paying for, they wanted them to be both used for meaningful clinical care, but also be safe. And they have this safety enhanced design kind of certification process. And essentially, it's really usability testing is what they do. So they get a number of users and they give them tasks and they get them tested by an independent company, and then they publish usability reports. And there's a big database of usability reports of all sorts of digital health systems. So it's quite a useful database, actually. A lot of these systems are used in the UK. So if you Google the name of your kind of EHR or prescribing system, quite often it's in this database, and they've got all these kind of usability tests to make sure that they're safe. WHO also have done quite a bit of work on digital health over the years. And in terms of evaluating digital health systems, they have a monitoring and evaluating digital health toolkit. And this basically gives kind of guidance to projects used mainly in low middle income countries, thinking about things like if someone's come with a kind of smartphone app they say is going to do something, how they should think about monitoring and evaluating that. And the main thing that they do is talking about at different stages of projects, what you should be thinking about in terms of how you monitor, and less about evaluation. I'll show you what they say about evaluation in a second, but saying things like, first of all, have a feasibility and usability with a small number of users, checking for system stability and performance. Thinking about efficacy with more users, so that's things like user satisfaction, workflow fit, how difficult it is to learn how to use, whether or not you're making errors when you're using it, how reliable it is. And then they differentiate efficacy and effectiveness. So they say efficacy is kind of a controlled setting, and then effectiveness is kind of when you go out into the real world. And this is then we've got tens of thousands of users, and this is when you look at kind of changes to processes, and changes in outcomes, whether that's for patients or systems. And then as it goes even bigger, thinking about implementation science, so looking at kind of total costs, coverage, changes in policy, and these kind of bigger effects. And so there's this kind of guide that's quite useful. You can go through, gives you lots of kind of information and kind of templates for thinking about how you monitor and evaluate things. When it comes to kind of what type of evaluation, they've kind of done the same thing as this kind of NICE framework, but it's actually pretty similar. The same actually for these different stages. So they just basically say that in terms of evaluation, your confidence in the strength of the evidence should be poor if it's editorials and expert opinion, fair if it's a descriptive study, good if it's an RCT, and excellent if it's a multi-center RCT. And the only difference is in implementation science, where they say quasi-experimental rather than RCT. I think that's the only difference there. Okay, so there's a few discussion points. There's a lot you could talk about here, and it'd be interesting to get some people's thoughts. So I've done a lot of talking, so it'd be good to bring in a few people now with some thoughts people have been mulling over. The thing that's interesting to me, and I've got a few kind of extra slides on this, which we can come back to if we want to, but what is the mode of action for a digital health intervention? That's kind of this kind of baseline thing that I think is quite an interesting concept. Is an RCT design, that's kind of this kind of high level evidence appropriate for digital interventions? So there's some little kind of problems with digital when it comes to RCTs. So it might be nice to think about those, and if anyone's got any thoughts about those, and I can say a few of my ideas around that. And also this emphasis on behavior change theory, is this the only way of thinking about the types of apps that are around behavior change? Is it a strong enough theory or group of theories that we should be thinking about there?